Welcome to the Deep Dive, where we take a stack of sources and really try to pull out the key insights for you.
Today we're diving into something we all have our skin, the integumentary system.
Yeah, exactly. Have you ever had, say, a small cut that needed stitches? Or maybe a mole looked a bit suspicious and needed checking out?
Happens all the time. And usually, we just trust the doctors to handle it.
Right. But do we really grasp what's happening after they say, okay, we need a sample here, or don't worry, we'll close that up?
Probably not the full picture. So that's our mission today. We're doing a deep dive into the fascinating and really precise world of medical procedures for skin, the tissues underneath, even parts of the breast.
We've gone through a whole collection of official medical source material.
And we want to unpack some of those hidden layers of care, the details that go into these surgeries.
So the idea is for you to understand not just what happens, but why certain techniques are used and, how meticulously everything gets recorded.
Yeah, hopefully you'll walk away feeling, better informed, maybe even a bit amazed by the level of detail involved. It's all geared towards accurate patient care, ultimately.
We'll cover things from, the most basic biopsies all the way up to complex skin grafts, reconstructions.
And we'll explore why knowing the type of incision or the depth of a wound or even how a tissue sample is taken makes such a difference.
Get ready for some interesting facts that definitely go beyond just the surface level.
Absolutely.
Okay, so where do we start? Maybe with those initial diagnostics, things like biopsies.
Sounds good. Let's start with something many have heard of. Fine needle aspiration, FNA biopsy.
FNA, right. Well, it sounds simple, just a quick needle poke.
Well, yes and no. With an FNA, a really fine needle is used. The idea is to aspirate or draw out material, usually cells for examination under a microscope, looking for abnormal cells, that kind of thing.
Okay, just cells. How's that different from, say, a core needle biopsy?
Good question. A core needle biopsy uses a slightly larger needle. It takes out a small core, a cylinder, of actual tissue, not just loose cells.
So you get more structure to look at.
Exactly. That tissue sample goes for what's called histopathologic evaluation, which gives a much more detailed picture of the tissue architecture.
Do they use imaging for these, like ultrasound?
Often, yes. FNAs and core biopsies, too, can be done with or without imaging guidance, things like ultrasound, CT, MRI. It's especially helpful for lesions that are small or deep, hard to feel.
Makes sense, for accuracy. Now, when they're documenting this, is the imaging guidance considered part of the biopsy procedure itself?
Generally, yes. For many of these FNA codes, for example, the imaging guidance used ultrasound, fluoro, CT, MR is often sort of bundled into the procedure description. It's seen as integral.
So they don't report it separately in those cases?
Typically not for those specific FNA codes, yeah. It reflects the whole guided process. And if a doctor needs to sample multiple lesions in one go...
How do they account for that?
It gets pretty detailed. Each lesion sampled is documented. Sometimes they use specific indicators, modifiers to show it was a separate site, maybe even using different imaging for different spots. It's all about precise record keeping.
That level of detail is really something, even for just taking a sample. Okay, what about other initial things, like draining fluid collections?
Right, like draining an abscess that's a pocket of pus, or maybe a hematoma, which is collected blood. A catheter, a small tube, might be inserted to drain it.
And the documentation.
The key thing here is clarity. If there are multiple separate collections and each needs its own catheter for drainage, each one is typically reported individually.
Okay, one catheter, one report, basically.
Pretty much. It ensures everyone knows the full extent of what was drained.
And placing markers, like those tiny clips or seeds we hear about, often for breast procedures.
Yeah, soft tissue marker placement. This uses imaging guidance again, ultrasound, MRI, etc., to put a localization device very precisely.
Like a little marker for surgery later.
Exactly. Think of them as tiny GPS trackers for surgeons or radiation oncologists, especially for things too small to feel. The procedure itself is reported once per target area, even if, say, a couple of clips are placed right there to mark that one spot.
And the imaging guidance for placing it.
Also generally bundled into that placement procedure code. Now, if there's a very specific code for that body part, like the breast, those more specific codes are used.
Got it. It's all about that pinpoint accuracy.
Yeah.
Okay, last thing in this initial phase. Incision and drainage, or I&D, We hear that term a lot.
We do, and it covers quite a range. It could be for an abscess, as we mentioned, or maybe something like a carbuncle that's a cluster of boils.
Lovely.
Yeah, or a furuncle, a single boil, or even a pilonidal cyst, that cyst near the tailbone some people get. It even includes removing a foreign object, like a splinter, from just under the skin.
So what makes one IND simple versus complicated?
Good question. It often boils down to factors like the depth, the size, how much infection there is, or if it's like multi-chambered, having lots of interconnected pockets that need draining.
So deep, complex infection is definitely complicated.
Definitely. Compared to, say, a small superficial abscess, the documentation reflects that complexity.
Okay, that makes sense. So we've covered some initial steps. Let's go a bit deeper now into removing tissue and repairing things. Debridement sounds important cleaning wounds.
It is. Debridement is the Mitchell term for removing tissue that's non-viable, meaning dead or dying or contaminated or infected from a wound. It's essential for healing.
How is it categorized? Because it sounds like it could apply to lots of situations.
It does, and the categorization is quite specific, reflecting the why and how much. For instance, if someone has, say, widespread eczema that's gotten infected and needs cleaning up,
Right.
that type of debridement is often coded based on the percentage of body surface area involved, like up to 10% or more than 10%.
So sheer size of the affected area matters there.
Precisely. Because cleaning a large area of inflamed skin is a different beast than a small wound. But then you have really serious situations like necrotizing soft tissue infections. Those are nasty, fast-spreading infections.
Like flesh-eating bacteria.
That kind of thing, yes. Often involving areas like the external genitalia or the abdominal wall. For those, the specific codes depend on the location and the depth of tissue that had to be removed. Skin, subcutaneous tissue, muscle, fascia.
Wow, okay, so location and depth for those severe infections.
Yeah.
What about more general wound debridement? Not those big infections, just say a wound that needs cleaning before closing.
Right. For those general debridements not linked to extensive infection or, say, an open fracture, the reporting gets really specific. It's based on two things. The deepest level of tissue removed.
Like just under the skin or down to muscle or even bone.
Exactly. And also the surface area of the wound being debrided, usually measured in square centimeters, like the first 20 square centimeters, then each additional 20.
So depth and area. What if someone has multiple wounds debrided?
Here's a key detail for you listening. If multiple wounds are debrided, they sum the surface area of wounds at the same depth, but you don't combine the areas from different depths.
Okay, so all the subcutaneous debridement areas get added together, separate from any muscle debridement areas.
You got it. That precision is vital for understanding the true extent of the work done.
It really highlights the detail needed. Okay, let's circle back to biopsies, specifically for sampling skin lesions. What's the main goal here and what techniques are used?
The core purpose of these specific biopsy codes, like 11102 through 111007, is to get tissue only for diagnostic microscopic examination. Just for diagnosis.
Just for diagnosis. So what if a doctor removes a whole lesion anyway and sends that for pathology? Is that also a biopsy?
That's a crucial point. If tissue is taken for pathology during another procedure, like an excision or a shave removal or destruction, that tissue examination is generally considered part of that main removal procedure.
So it's not billed as a separate biopsy.
Correct, because the main purpose was removal, not just diagnosis. This prevents, double counting and clarifies the primary reason for the procedure.
That makes a lot of sense. Okay, so what are the actual biopsy techniques when the sole purpose is diagnosis?
There are basically three main types described. First is tangential biopsy. Think of this as superficial. Uses a sharp blade to shave or scoop off a sample. It gets epidermis, maybe some dermis, but doesn't go full thickness.
Okay, like skimming the top.
Sort of. Then there's punch biopsy. This uses a tool that looks like a tiny cookie cutter, a punch tool. It takes a full thickness, cylindrical sample. A simple stitch or two to close the little hole is usually included.
A little core sample.
Exactly. And finally, incisional biopsy. This also gets a full thickness sample, but instead of a punch, it uses a scalpel to make a vertical cut or take a wedge. It goes down into the subcutaneous fat layer. And again, simple closure is typically included.
Got it. Tangential, punch, incisional. What if a doctor uses, say, a punch on one mole and a tangential shave on another spot in the same visit?
Good scenario. In that case, if you're using different techniques on separate lesions during the same session, they're generally reported starting with the most complex technique first, then using add-on codes for the additional biopsies.
It all gets tracked very precisely.
Absolutely, it has to.
Okay, shifting from just sampling to actually removing lesions,
Yeah.
there's shaving versus excision. They sound different.
They are quite different in technique and intent. Shaving, which uses codes like a less 1300 to a 1313, is for removing epidermal or dermal lesions, think raised moles. Skin tags using a sharp blade horizontally, like shaving it off parallel to the skin surface.
And usually no stitches needed.
Typically not, no. It's more superficial. The specific code used depends on the body location, trunk, arms, legs, versus scalp, neck, hands, feet, versus face, ear, slips, and the size, the diameter of the lesion shaved.
Okay, so location and size matter for shaving. What about excision then? Sounds more involved.
It is. Excision, specifically for benign lesions first, codes 11400 or 11471, means full thickness removal. Cutting through the dermis, getting the whole lesion out, including a margin of normal skin around it.
Margins are important even for benign.
Often, yes, to ensure complete removal. And excision always includes a simple closure like stitches.
How do they measure for coding and excision? Just the lesion size.
This is critical. The code is based on the excised diameter. That's defined as the greatest clinical diameter of the lesion itself, plus the narrowest margins needed for complete removal. And crucially, this is measured before the skin is cut.
Before cutting, why?
Because once you cut, the skin can retract or change shape. Measuring beforehand gives the most accurate size of what needed to be removed.
That's a clever detail.
Yeah.
So simple closure is included, but what if it needs more?
Right. If the closure requires more than just a simple single-layer stitch-up, if it needs an intermediate or complex repair, which we'll get to, then those more complicated closures are reported separately in addition to the excision code.
Okay. And this section also covers things like hidradenitis, those inflamed lumps.
Yes, excision of hidradenitis has its own specific codes within this benign excision range, varying by location like armpit, groin, perianal area, and whether the repair was simple, intermediate, or complex.
Gotcha. Now, what about excision of malignant lesions, skin cancers? Codes 11600 plus 1646.
The basic principles are very similar to the 9 excisions. It's full thickness removal, it includes margins, simple closure is bundled in, and the code is based on that pre-excision measurement of lesion plus required margins.
Same measurement rule.
Yep. This applies to the common skin cancers, basal cell, squamous cell, melanoma.
What if the margins aren't clear after the first excision? They need to take more.
Good point. If the initial pathology check shows the cancer wasn't fully removed at the edges and the surgeon needs to go back and take more tissue in the same surgical session.
Right then and there.
Yes, then you just use one code based on the final widest diameter of tissue removed in total during that session. However, if the re-excision for margins happens in a later separate surgical session,
like days or weeks later.
exactly, then specific codes and a modifier, like modifier 58, are used to show it's a planned, staged procedure related to the first one.
That detail ensures the whole story of the treatment is clear. Okay, this leads us perfectly into the actual closure, the repair part.
Yeah.
It's not just stitching, is it? There are levels.
Definitely not just stitching. Wound repair or closure is meticulously classified into 3 types: simple, intermediate, and complex. This framework guides how the closure itself is documented.
Okay, let's break those down. Simple repair. Codes 12,001, 1121.
Simple is basically superficial, one-layer closure. It involves mainly the epidermis, maybe the dermis, or just subcutaneous tissue just below the skin. Methods include sutures, staples, or even tissue adhesives like surgical glue.
So stitches, staples, or glue for a straightforward single-layer close.
Right. But here's a key point. If a very minor wound is closed only with adhesive strips, like steri strips, or just by chemical cauterization.
Like burning the edges to stop bleeding.
Kind of, yeah. That type of closure alone usually isn't reported as a separate repair procedure. It's often considered part of the basic evaluation and management service, like the office visit code.
Okay. So simple repair needs a bit more than just tape. What about intermediate repair? Codes 12031, 10207.
Intermediate steps it up. It requires layered closure. That means closing deeper layers, like the subcutaneous tissue or the superficial fascia below it, in addition to closing the skin layer.
So multiple layers of stitches inside.
Often, yes. Or an intermediate repair code might also be used for a single-layer closure if the wound was heavily contaminated and needed really extensive cleaning or removal of particulate matter before closing. It also includes limited undermining.
Undermining. What's that?
It's where the surgeon gently separates the skin edges from the underlying tissue just a little bit. This helps free them up so they can be brought together without tension for a better closure. Limited undermining is part of an immediate repair.
Okay, layered closure or heavy cleaning.
Yeah.
Then what makes a repair complex? Codes 13100, 13160.
Complex repair is the most involved. It has to meet the requirements for an intermediate repair plus at least one additional criterion from a specific list.
Like what?
Things like exposure of deeper structures like bone, cartilage, tendon, or a named nerve or blood vessel, or requiring debridement of the wound edges, trimming away irregular or devitalized tissue before closing, or performing extensive undermining.
How extensive is extensive?
It's actually defined. Undermining where the distance the skin is freed up is equal to or greater than the maximum width of the defect being closed.
Okay, specific definition. What else makes it complex?
Involvement of delicate free margins, think the curved rim of the ear, helical rim, or the red border of the lip vermilion border. Or if special retention sutures are needed, those are deep, strong sutures placed to take tension off the main closure line.
Wow, that's a lot of specific criteria. So how do they measure and report these, especially if someone has multiple cuts?
Good question. Repairs are measured in centimeters. When multiple wounds are repaired, you sum the lengths of wounds that are in the same classification, like all simple repairs together, and located in the same anatomical group. For example, all simple repairs on the face, scalp, neck group.
So you add up all the simple repairs on the arm, for instance.
Exactly.
Right.
But you don't add lengths from different classification, like simple plus intermediate, or from different anatomical site groups, like arm plus leg.
What if someone has, say, an intermediate repair on their leg and a complex repair on their face?
Then you report the more complicated one, the complex repair on the face, as the primary procedure, and the intermediate repair on the leg as a secondary procedure, often using a modifier like 59 to show it's distinct.
It's like a coding hierarchy based on complexity and location.
Precisely. It creates a clear, standardized record.
Okay, beyond direct closure, there's adjacent tissue transfer or rearrangement ATT. Codes 14,000, 14350. How is this different?
ATT is about using nearby, local tissue to close a defect. It involves designing and moving a flap of adjacent skin and subcutaneous tissue techniques like Z-plasty, W-plasty, rotation flaps, advancement flaps.
So you're actually rearranging the local landscape, so to speak.
Exactly. It's often used for defects that are too large or complex for a simple side-to-side closure. A really key difference here is that ATT codes include the initial work of creating the defect, like excising a lesion, and the flap repair itself.
So the excision of the lesion isn't reported separately when you do an ATT.
Correct. That initial excision is bundled into the ATT code. It avoids double counting the removal part.
How is the size measured for ATT?
The defect size for coding ATT includes both the primary defect, what the lesion was, and the secondary defect created by moving the flap tissue. You measure the total area involved in the rearrangement.
Got it. And just undermining the skin edges isn't enough to call it ATT, right?
Right. Undermining alone, even extensive undermining to achieve closure, falls under complex repair, not ATT. ATT requires designing and moving a distinct flap of tissue.
Okay, now we're getting into even more involved stuff. Skin replacement surgery. This sounds major.
It often is. This is a broad category for procedures where you prepare a wound bed and then cover it with either an autograft skin taken from the patient's own body or a skin substitute.
Skin substitutes, like artificial skin.
Sometimes, or it could be skin from another human source, homograft, non-human source, xenograft, or various biological or synthetic materials designed to act like skin or encourage skin growth.
Before you put on a graft or substitute, does the wound need special preparation?
Yes, and there are specific codes for surgical preparation. 1502, 15005. This isn't just basic cleaning. It means preparing a clean and viable wound surface, often by removing non-viable tissue from burns, major trauma, or infections, specifically to get it ready for a graft, flap, or substitute. It's distinct from chronic wound debridement codes.
Got it. Now, you mentioned something earlier that sounded really advanced. Skin cell suspension autograft, SCSA, codes 150-15018.
Ah, yes, SCSA. It's a fascinating technique. You harvest a relatively small piece of the patient's own healthy skin epidermis and dermis.
Okay.
Then, Through enzymatic and mechanical processing, you create a liquid suspension containing the patient's own skin cells.
A spray-on skin solution almost.
Essentially, yes. This cell suspension is then applied, often sprayed, onto the prepared wound bed. The amazing thing is the expansion potential.
How much expansion?
You can take a small donor site, maybe 25 square centimeters, and generate enough cell suspension to cover a wound up to, say, 2,000 square centimeters. That's an expansion ratio of like 1 to 80.
Wow. That's incredible for large wounds or burns.
Absolutely. It minimizes donor site morbidity while maximizing coverage. The codes cover the harvesting, preparation, and application.
What about more traditional autografts? Codes 15040, 15261, taking pieces of skin.
Right. This includes different types: pinch grafts, tiny pieces, split thickness grafts, epidermal grafts, dermal grafts, full thickness grafts, epidermis, and all of the dermis.
Where do they take the skin from?
A healthy donor site on the patient's own body. The harvesting of that graft is considered part of the grafting procedure code itself.
What about fixing the donor site? Does that get reported?
Usually simple closure of the donor site is included, but if the donor site itself needs a significant repair, like needing its own skin graft because it was so large, then that donor site repair could be reported separately.
Okay. And skin substitute grafts.
Yeah.
Codes 15271, 15278. Using materials that aren't the patient's own skin.
Exactly. This is when you apply those non-autologous options, homografts, xenografts, or other biological synthetic scaffolds. An important point here is that the supply of the skin substitute material itself is usually reported separately from the procedure code for applying it.
So one code for the material, one for the surgeon's work of putting it on.
Generally, yes.
And finally, in this reconstruction area, we have flaps. Codes 15570, 15778. How are these different from grafts?
Flaps are a step up in complexity usually. While a graft is a piece of tissue completely detached and moved, a flap involves moving a larger section of skin, often with underlying fat, fascia, or even muscle, while keeping part of its original blood supply attached.
That stays connected.
Yes, through a base or pedicle. This connection maintains blood flow, which is crucial for the survival of larger or thicker tissue transfers, or when placing tissue over areas with poor blood supply, like exposed bone or tendon.
So the planning must be intricate.
Extremely. Flaps are categorized by how they're formed. If there's a delay involved, like partially raising the flap first to improve its blood supply before fully moving it, and the transfer itself.
What are some types?
There are many. Adjacent tissue transfer flaps we mentioned earlier. Then there are distant flaps, moved from one body part to another. Specific types include forehead flaps used for nasal reconstruction, muscle flaps, myocutaneous flaps, muscle and skin, fasciocutaneous flaps, fascia and skin. The choice depends entirely on the defect's size, location, and needs.
Are there even more specialized flaps?
Oh, yes. You have things like island pedicle flaps, where the flap is moved on a single, specifically dissected artery and vein, or neurovascular pedicle flaps, which include a functional nerve along with the blood supply, aiming to restore sensation or even motor function, perhaps in hand reconstruction.
That's incredible surgical artistry. What about newer techniques?
We're also seeing more autologous fat grafting, harvesting fat via liposuction and injecting it to fill defects or improve contour, and the use of biologic implants, often meshes, for soft tissue reinforcement, like in complex hernia repairs or breast reconstruction.
It's constantly evolving. Okay, let's touch on a couple of specialized areas before we wrap up. Pressure ulcers, also called decubitus ulcers.
Right. Codes 15920, 15999. These are injuries from prolonged pressure, often over bony areas. The procedures involve excising the ulcerated tissue, sometimes including removing underlying bone if it's affected, that's ostectomy, and then closing the defect, which often requires a skin flap due to the location and tissue loss.
The codes vary by location, like tailbone, hip.
Exactly. Coccygeal, sacral, ischial, trochanteric. The location dictates the specific code, along with whether bone was removed or a flap was used.
Makes sense. And burns. How is their local treatment handled? Codes 16,000 Bunchy 16036.
Burn treatment codes cover the initial care. Things like treating first-degree burns or applying dressings and performing debridement on partial thickness burns.
How are those categorized?
Often by the size of the burn area being treated small, medium, large, usually based on body surface area percentages. There's also a specific procedure called escharotomy.
What's that?
It's a surgical incision made through the tough burn spin, the eschar, to relieve pressure. Deep burns can constrict the underlying tissue, cutting off blood flow, so this release incision can be limb-saving or even life-saving.
And they use specific methods to estimate burn size, right?
Yes, a common one is the Lund-Browder chart. It's helpful because it adjusts the body surface area percentages based on age, recognizing that, for example, an infant's head makes up a larger proportion of their body surface than an adult's.
That age adjustment is key for accurate assessment. Okay, almost there. Destruction of lesions. This isn't cutting them out.
Right. Destruction means ablating or eradicating lesions using methods other than excision. Think laser, electrosurgery using electrical heat, cryosurgery, freezing with liquid nitrogen, chemosurgery using chemicals, or surgical curette scraping.
What kinds of lesions are treated this way?
It can be benign lesions, premalignant ones, or even certain malignant lesions. The coding distinguishes between these categories.
So for premalignant lesions, like those actinic keratoses you mentioned, code
Yeah.
17,000 range.
Exactly. For those common sun damage spots, there's specific coding. Typically one code for the first lesion destroyed, another add-on code for lesions 2 through 14, and then potentially another code if 15 or more are destroyed in the same session.
That shows how common it is to treat multiple spots at once.
It does. It reflects the need to track the extent of treatment systematically.
And then there's a very specialized type of destruction or removal, Mohs micrographic surgery, codes 23311, 1 scene 35 Kine. What makes Mohs unique?
Mohs is really distinct. It's primarily used for certain skin cancers, especially those in cosmetically sensitive areas, or ones with poorly defined borders or recurrent tumors. The defining feature is that the surgeon acts as both surgeon and pathologist during the procedure.
How does that work?
The surgeon removes a thin layer of the tumor tissue, carefully maps and color codes it, and then immediately processes and examines 100% of the surgical margin under a microscope right there in the office lab.
While the patient waits.
Yes. If any cancer cells are seen at the margin, the surgeon knows exactly where they are based on the map, goes back, removes another thin layer only from that specific positive area, and examines it again. This process repeats until all margins are clear.
So it maximizes cancer removal while saving the most healthy tissue.
Precisely. That's the goal. The Mohs codes include the removal, the mapping, the microscopic examination by the surgeon, and the tissue prep.
What about closing the wound after Mohs?
Ah, good point. Any subsequent repair, whether it's simple closure, a flap, or a graft, needed to fix the defect left after the Mohs removal is reported separately using the appropriate repair or reconstruction codes we discussed.
That makes sense. It's a two-stage process conceptually. Okay, last area. Breast procedures, codes 19,000-10-499. What's the focus here in relation to skin and tissue?
We're mainly looking at biopsy and localization techniques here. Breast biopsies can be done percutaneously using a needle, often a core needle, guided by imaging.
Like ultrasound-guided or MRI-guided.
Exactly. Or they can be open incisional biopsies requiring a small surgical cut.
And the imaging for needle biopsies, bundled again.
Yes, for many image-guided breast biopsy codes, the placement of a localization clip at the biopsy site and the imaging guidance itself, ultrasound, stereotactic, MRI, are all bundled into the single biopsy procedure code.
That seems efficient.
It reflects the integrated nature of the procedure. These codes also often include imaging the specimen after it's removed, just to make sure the targeted area was sampled. There are also specific codes for things like cryosurgical ablation, using freezing to treat benign breast tumors like fibroadenomas, and again, the ultrasound guidance is typically included there too.
So all this ensures that even tiny, non-palpable spots can be accurately targeted for diagnosis.
That's the goal: precision for reliable diagnosis and patient peace of mind.
Wow. Okay, so stepping back, we've really journeyed through the integumentary system today. It's incredible the level of detail and precision that goes into these surgical procedures.
It really is, from, the subtle differences in biopsy techniques to the complex planning of reconstructive flaps.
What really stands out to me is not just the medical skill, but the incredibly meticulous system behind it all. This language of codes that translates complex actions on the human body into standardized, reportable information.
It's fundamental. It's a testament to how much effort goes into accurate documentation, which is crucial for continuity of care, for research, for everything, really. It's all about ensuring quality patient care.
So the next time you hear about someone having a skin procedure, or maybe even if you have one yourself, you'll have, hopefully, a much deeper appreciation for the thinking, the skill, and that systematic approach behind every cut, every stitch, every sample taken.
You'll know that behind what might sound like a simple description, removing a mole, closing a cut, there's this whole world of detailed classification ensuring things are done right and recorded properly.
It really shows how deeply connected precise medical knowledge is with the language we use to describe and manage healthcare. And it leaves you thinking,
What else is out there?
yeah, if this much intricate detail applies to just the skin and related tissues, imagine the layers of complexity defining procedures for every other part of the body. What other hidden systems of classification and care are operating beneath the surface, just waiting to be understood?
It's a fascinating thought, isn't it? Always more to learn.